Welcome to the December AMSSM Journal Club meeting. My name is Carol Chang, and I will be serving as the club advisor, moderating tonight's Journal Club meeting. I'm currently a sports medicine fellow at Swedish Medical Center in Seattle, Washington. I completed my PM&R residency at Rush in Chicago. So the goal of the AMSSM Journal Club is to provide a national platform for student and resident members to present an article from the list of the top 120 articles that sports medicine fellows should be familiar with. Our intent is to make this a fun learning experience to give both students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. So we'll be having 3 presentations tonight. The format of the meeting will be that each presenter will have approximately a 20-minute block of time that includes the presentation as well as a brief Q&A segment after their presentation. If you have any questions, you can enter them into the chat and I will call on you and you can ask your question to the presenter. So the first presenter can start pulling up their presentation. So I'll make a quick introduction. Our first presenter tonight is Dr. Rajit Banerjee and his club mentor, Dr. Chad Asplund, who is also one of the authors for the article that Dr. Banerjee is presenting. Dr. Banerjee is a current second-year resident in the Department of Physical Medicine and Rehab at the University of Pittsburgh Medical Center. He grew up in Cincinnati, Ohio, and attended college at the University of Toledo, majoring in biomedical engineering. He continued medical school at the University of Toledo, discovering his passion for PM&R and later sports medicine. Within sports medicine, he has clinical interests in adaptive sports and pediatrics. His research interests are in musculoskeletal injury, biomechanics, wearable sensor technology, diagnostic ultrasound, and hoping to apply engineering principles into sports medicine rehab. His presentation is on the article Splints and Casts, Indications and Methods. I'd also like to thank Dr. Chad Asplund for serving as his club mentor. Dr. Asplund currently serves as a professor of family medicine and orthopedics at Georgetown University in Washington, D.C., and is currently the head team physician for Georgetown University Athletics. Dr. Asplund also currently serves as the medical director for the USA Basketball's junior national team and the team physician for USA Hockey. He has done research in concussion, sudden cardiac death, exertional collapse, and sports cardiology. Dr. Asplund is a past president of the American Medical Society for Sports Medicine. All right, Dr. Banerjee, you can take it away.
All right, can everyone hear me and see the PowerPoint slide? Thumbs up. All right, okay, cool. So thank you, Dr. Chang, and thank you to AMSSM, Dr. Asplund, and Joan for setting this up and allowing me to do this journal club presentation. And so this is on splints and casts, which indications and methods. This is more of a review article, so it's not your typical journal that has a study design and materials and methods, but regardless, it's a really important article that's out there and really laid the foundation of indications for splints and casts for various musculoskeletal injuries. So without further ado, get started. As a brief introduction, the main goal of splints and casts is to immobilize musculoskeletal injuries to eventually reduce pain and promote healing. And usually this is done in acute settings, but it can be done for chronic settings. To apply certain splints or casts, providers really have to know not only the diagnosis, but also the stage and severity of the illness, as well as functional implications. And so what we have here on the left is a splint. It's non-circumferential. So what that means is that it allows swelling in the acute phases. And so it can be used chronically as well for pain control and to promote function. Whereas you have casts on the right, these are circumferential. And these allow for more stronger immobilization. And so usually the indications for these are for more complex fractures or definitive management. And so briefly, advantages, disadvantages. Advantages for splints: varied functional use. It's faster, it's easier to apply. There's less risk of complications, and there's a lot of commercial splints that are available for certain injuries. And so there's quite a different ways that you can use a splint for a particular musculoskeletal injury. One of the disadvantages is that there is a lack of compliance, whether that's from patient education or just from the ease of use of using the splint, as well as the ease of not using it. Some of those factors do play into the role of the lack of compliance. And obviously, it's not useful for definitive care for unstable fractures. Casts, on the other hand, are effective at immobilization. But one of the bigger disadvantages with casts versus splints is that there are higher complication rates. And so what are these complications? There's quite a few of them, but mainly they revolve around skin stuff that's related to deep pressure injuries or superficial pressure injuries, skin breakdown, infection. You can also get ischemia and heat injuries. Depending on the type of cast or splint that you're using and where you're using it in the body, you can get certain neurological deficits too if it's affecting a peripheral nerve. Sometimes if it's not aligned or misaligned from placing it, patients can get certain types of nerve compressions. One of the more worrisome things are compartment syndromes, which is classically the 6 Ps. And then for continued use of casts, you can get issues with pain, stiffness, muscle atrophy, and even CRPS, which is complex regional pain syndrome. In the rehab setting, we sometimes do see CRPS, which is basically chronic pain out of proportion to the severity of the injury. And so it's usually a diagnosis of exclusion, and it's pretty difficult to treat. But you can see here, pressure injuries, you want to avoid, provide adequate padding for places that have bony prominences. And so in general, for applications for splints and casts, you start off with a stockinette, which is a knitted stretch fabric. You apply a cotton layer and then a wet splint over the padding, and then you can secure it with an elastic bandage. You can also do it without the stretch fabric and just apply the wet splint and then just mold it with the elastic bandage. The main difference with the splints and the cast is that basically with the cast, you're applying more of that plaster and the fiberglass, which offers more of that immobilization and rigidity. And so it's really about that material with the cast that makes it different. So now we can kind of get into talking about the upper extremity splints. And so the first one I want to talk about are the radial or ulnar gutter splints. And so the ulnar gutter splint, that is used mainly for 4th and 5th metacarpal injuries, particularly stable fractures or soft tissue injuries. And so this is kind of a picture that shows what it looks like. You want to keep essentially the MCPs at a 70 to 90 degree flexion and the PIPs at a 5 to 10 degree flexion. And so it leaves the thumb and the index finger. And classically, you can have a 5th metacarpal fracture that's called a boxer's fracture, and that's commonly an injury where you can use an ulnar gutter. And then you have the radial gutter, similar concept, except it's used for the 2nd and 3rd metacarpals. And you're also keeping the MCP at 70 to 90 degree flexion. One of the main things to just recognize is that if you have an angulation or a rotation at the fracture site, that can cause functional problems like difficulty to grasp or pinch or even thumb opposition. And so that sometimes does require discussion with orthopedics if splint or casting is the way to go for those. The next we have is thumb spica. So that's used for scaphoid injuries, first CMC arthritis de Quervain's. And so how this cast is put on is basically it starts in the forearm and basically goes up to the interphalangeal joint. And the hand is held in a position of function where the wrist is extended to 25 degrees. And so this is commonly called the soda can sign because that's the optimal position to keep it at. And then some clinical pearls associated with this is that with scaphoid fractures, you want to make sure that if it's a proximal fracture, that's when you're more prone to have avascular necrosis due to the lack of blood flow, as you can see here. So for those, that requires more of a surgical approach and referral to orthopedics. And then for decorative veins tenosynovitis, that's a inflammation swelling that occurs at the junction of the extensor pollicis brevis and the abductor pollicis longus tendon. That one is a classic Finkelstein's test where you are adducting your thumb and ulnar deviating to reproduce that pain. Good way to remember the tendons here is that all peanut lovers eat peanut butter. So that's APL and EPB. Moving on to buddy taping. So this is more for use in minor finger sprains. Sometimes in basketball, football injuries, you can get kind of a valgus force that occurs on these collateral ligaments. And sometimes even stable shaft fractures, you can use this as well. And basically what you do is you take that injured finger and you tape it to the adjacent finger to allow for healing. The dorsal extension block, that's actually used more for severe finger fractures like phalangeovolar avulsions and even PIP joint dorsal dislocations. And so the main goal here is that you eventually want to get the finger back to extension. And when you apply this dorsal extension block, it's initially applied with the PIP at like 45 degrees flexion. And so what you have to do essentially each week is to have a slow graded extension about 15 to 20 degrees. And you want to reassess with frequent radiologic imaging to make sure that all the bony alignments are intact. And you do that for about 4 weeks to make sure it gets into full extension. And then now kind of moving more from distal to proximal, you have now your carpal fractures. And one type of splint that you can use here are your forearm splints. The main thing to realize is that it does not limit forearm pronation supination. And then similar to the forearm splint is a short arm cast. And again, because it's a cast, it offers a little bit more immobilization. It's mainly used for distal radius fractures. So those are your Colles and Smith fractures. So your Colles fracture, that's where you have the distal fragment that is displaced dorsally. And then the Smith fracture, the distal region is basically displaced more in the volar direction. And again, similar to the forearm cast, it does not limit forearm pronation and supination. And then we have the single and double sugar tongue splints. So the single sugar tongue splint is used for distal radius and ulnar fractures, similar to the other splints that we talked about. The double sugar tongue splint, that is used more for elbow injuries and even proximal forearm injuries, including Colles fracture. And one of the most important things to note about the double sugar tongue splint is that it does not limit supination and pronation. And you can see here, it makes sense because you have one tongue here and one tongue that basically wraps around and goes up to the humerus. And so when you have that basically applied on both sides, you limit pronation and supination. And that's ideal, particularly for fractures that are super unstable or complex. So that's when you would want to use a double sugar tongue splint. So now we move on to the lower extremity, and this is the posterior ankle splint. And so this is mainly used for severe ankle sprains, non-displaced malleolar fractures. And the way this splint is applied is at a prone position. So you want to have your patient at prone position and have the knee and ankle flex at 90 degrees. The main thing to note here is that in this section, the splint does not extend there. And the main reason for that is that you want to avoid any peroneal nerve compression. And so if you remember, the peroneal nerve wraps around the fibular head and then separates into your superficial and deep peroneal nerve. And so depending on, where the injury happens, sometimes, if a splint is not a splint or cast, if it's not properly made, it can cause a certain degree of impairment. In the rehab department, sometimes we see people come in for foot drop that have had either their brace or their cast that just is a little bit too high up. Similar to that is the stirrup splint. So that is also used for acute ankle injuries. It's more for a short-term treatment. And per the article, there's more evidence that favors using a soft lace-up brace, shown here on the right. You can see here that it offers more functional benefit, and then it does limit more of that inversion eversion. When you have those ankle sprain injuries, particularly ones that are more common with inversion affecting the ATFL or the CFL ligaments, and even the medial side affecting the deltoid ligaments, this helps prevent that inversion eversion. And then moving on to the short leg cast, this basically extends beyond the ankle, and you can use it for fibular fractures and also for metatarsal fractures as well. So main thing to note with this is that, again, it's a cast. So you want to make sure with the leg, there's a lot of bony prominences with the malleoli, and making sure that there's padding, enough padding in those regions. And you can notice here that it actually keeps the toes open. You're actually okay with allowing some range of motion with ankle dorsiflexion and plantar flexion. And this is different from a toe plate extension where you actually want to immobilize the toe because there is a fracture at the distal metatarsal and the phalangeal regions. And so if there's essentially a fracture here, you actually want to limit the ankle plantar dorsiflexion. So you can see that toe extension versus keeping it not intact here. And then finally, you have the posterior knee splint. This is usually used in instances when the knee immobilizer can't be used. And so it's used mainly for soft tissue injuries like quad or patellar tendon ruptures, or for ACL issues as well. So in general, for follow-up, it can vary based off of the type of injury that you have and whether you have a splint or cast. But in general, follow-ups are usually 1 to 2 weeks. And the main things that you're looking for are pain, paresthesia, color changes, any of those acute changes that make you worrisome for like CRPS or for compartment syndrome as well. So those are things that you want to watch out for. Things for referral, you want to make sure that you're identifying if it's a displaced or unstable fracture. Usually those require referrals to orthopedics. For certain joints, especially for metacarpals, referrals are placed for angulated, rotated, and oblique fractures. So kind of like what we talked about before, especially in the hands, if that is limiting function in grasping or thumb opposition, the splint or cast may make it worse if the underlying fractures aren't addressed. Some of the newer options for splinting and casting, again, not a lot has changed, but we talked a lot about issues in the forearm and in the carpal and metacarpals, but what about fractures in the humerus? And so for those, you can use what's called a coaptation splint. It's essentially a sugar tongue that you use for the upper arm rather than the forearm. And important thing to note is that it's got to pass through the deltoid and through to the axilla. So you want to ensure that it's passing the area of region that has the injury. And then there's the controlled ankle movement boots or CAM boots that I'm sure a lot of us have seen. It's usually used for metatarsal shaft fractures, toe fractures, and even ankle fractures that don't have indications for operation. And so it has pretty good range of uses for a variety of musculoskeletal conditions, and it offers pretty good benefits both from a function standpoint and from an acute standpoint in terms of reducing swelling and pain. The last thing I want to just mention, this is kind of getting out of the scope of the article, but it's mainly to address the differences of splints and casts versus bracing. A lot of the time, these terms are used interchangeably, and so it's important to make sure those two terms are different. Both do address immobilization to some degree and aim to improve overall function. With splints and casts, which is what for the majority part of the time what we've talked about today, it's mainly used for acute phases, for reducing pain and swelling and promoting healing. Bracing, on the other hand, is used, again, it's it's not exact, but in general, it's used more for chronic phase. Main goal is for function and performance and to prevent further deformity. So you can kind of think of it as splints and casts is more for treatment and curative measures. Immobilization, bracing is more for function. And so regardless of whether you're prescribing splints or casts or braces, it's similar to prescribing medications. When do you give it, for what activities, and for how long, should these braces or splints and casts should be applied for each of the scenarios. And so just as a brief example, in the rehab setting, we commonly see patients who have cerebral palsy, which is a brain injury in children, and they develop these gait patterns called crouch gait, where you have excessive hip, knee flexion, and ankle dorsiflexion. So when you have that, that really makes ambulation or walking difficult. And sometimes we provide, it's useful to provide ankle foot orthoses, which helps align the knee joints and provides less energy expenditure to walking. And there's a lot of research going on now in terms of using braces for adaptive sports, not only to reduce pain, but also to promote function and performance. I just want to thank everyone for tuning in, and want to thank AMSSM and Dr. Asplund for helping me in this journal club and their mentorship. Open to any questions and comments as well.
Thanks, Dr. Banerjee. That was a good presentation. We'll take this time to let Dr. Asplund make any additional comments. Dr. Troxler had put 2 good questions into the chat that Dr. Asplund, if you can speak to those for those on the video, that would be great too.
Great, thank you. Raj, great job. AMSSM, thanks for putting this out there. Mark, thanks for your questions. Let me see if I can get them. So Mark's first question is what can we or the patient do to prevent complications of placing a cast? I think the most important thing is you need to wait for that acute phase of swelling to pass before you place the cast. And so typically, the first 72 hours after an injury before you put a cast on. And typically, if you think about Football Friday and you see something maybe in your Saturday injury clinic, probably, better off to put that in a splint and then get it referred to ortho or wherever your casts are placed, whether you do those in your clinic on Monday or Tuesday to put a cast on that. I think one of the things Raj highlighted towards the end of the presentation, and I know the article was on splinting and casting, but there are now so many kind of off-the-shelf options. I mean, cam boots have really revolutionized kind of the way that we manage, lower extremity stuff. I mean, old timers like myself, remember the days of walking casts and things like that. But now pretty much everything goes in a boot, and there's been really good research to show that removable wrist splints are just as effective as casts for distal radius fractures. And so I think some of the data is changing. So you want to wait for the acute phase to pass. 2, you need to know how to properly apply a cast. If you don't do it right, the risk of complications would go up, of course. Plenty of padding. Hopefully, if you've had the opportunity to do a splint or cast workshop, you had the opportunity to use the the felt or the padding to make sure that you're padding that enough, especially over those bony areas. If you think about the wrist, the ulnar styloid, kind of the areas that are going to rub. You want to then place the extremity in an anatomic position. Casting it in an inappropriate position is going to lead you to potential complications. And so those are the main things that I can think of. And then I usually will touch base with patients either later that day or certainly the next day, just to make sure that they're doing well, that there's not a hot spot in the cast, that they're not noticing any problems. And then, don't feel bad if you've got to redo a cast. Sometimes, the swelling will reoccur. Sometimes the patient moves after you had the cast in a good spot. And so certainly sometimes you've got to redo the cast for patient comfort. And so those are the main ways to sort of reduce the complications. The other question Mark asked was, what can be done so I can swim with my cast or surf? There are certain types of fiberglass that are quote unquote waterproof. They're not really waterproof. They just absorb less water. The padding that you put under there obviously absorbs water. And so there are some traditional casts that you can use in water settings. The newer stuff out there, the thermoplastic splints and casts, the moldable stuff that you kind of pop into that little toaster oven and then you mold to the patient, and they've got the little BOA dial that can help you tighten them in. We've been using those since I was at Ohio State, and in our swim athletes, if they had a broken wrist, we'd have 2 of those thermoplastic splints for them, and swap them out as their swim practices changed. One could be drying while they were wearing the other one, and vice versa. And so there's a lot more over the counter stuff, off the shelf stuff. JC asked any preference between plaster versus orthoglass. Mark, I think, did a nice job answering. Fiberglass for stable fractures, plaster for unstable. A lot of it depends on what's available in your area. Fiberglass is becoming more and more available, and a lot of the, those sheets of fiberglass that they put out there are just typically more available than plaster. But if you have a true ortho clinic with a cast clinic, they're going to have both the fiberglass and the plaster. There are roles for each, and if you go to this article was indications and methods, which was part 2 of the splints and casts. If you go back to part 1, it will really talk about when to use fiberglass, when to use plaster, kind of the pluses and minuses of each. And so another good article, number 1 there.
And Dr. Asplund, is this like a second part of that series, like that article that you were talking about was the first one, right?
Yeah, so this is the second part, and I apologize if I was on mute for all of that. I hope I wasn't, but the second part, this is part 2 of a 2-part article. The first one was practical, essentially, I forget the exact name of it, but it was sort of like the how-to splints and casts. And then this second part of the article was kind of more practical, like if you have this extremity, you want to use this splinter cast versus the other. First one was a lot more on sort of theory and sort of the thought process behind it.
All right, thank you, Dr. Banerjee and Dr. Asplund. We're going to move on to, we'll move on to the second presenter. So you guys can get that set up while I introduce you guys. So our second presenters tonight are Dr. Aundrea Busse and her club mentor, Dr. Carly Chamberlain. So Dr. Busse grew up in Ohio prior to completing her higher education in the Bluegrass State. She received her Bachelor of Science in Human Nutrition from the University of Kentucky while also competing on the cross-country and track and field teams. After her time at University of Kentucky, Dr. Busse completed her medical education at the University of Louisville. She is currently a first-year resident at the Indiana University School of Medicine Family Medicine Residency. Her presentation is on the 2014 Female Athlete Triad Coalition Consensus Statement on the Treatment and Return to Play of the Female Athlete Triad. I'd also like to thank Dr. Carly Chamberlain for serving as her club mentor. She is a graduate of the Lake Erie College of Osteopathic Medicine. She completed her family medicine residency at Christiana Care in Delaware, where she served as chief resident in her 3rd year. She also completed her primary care sports medicine fellowship at Christiana Care, and she now practices primary care sports medicine at the University of Pennsylvania Student Health. She has a special interest in the care of the female athlete in medical education. All right, Dr. Busse, I'll turn it over to you.
Hi, thank you for that great introduction, Dr. Chang. I'd like to thank the AMSSM for hosting this and Dr. Chamberlain for her great mentorship through this. So I'm presenting on the 2014 Female Athlete Triad Coalition Consensus Statement. So not necessarily a traditional study, but a great overview and practice guide. Little disclaimer, we were asked to review the 2014 consensus statement, but as some of you may know, the 2023 consensus statement on relative energy deficiency in sport was recently published by the IOC. So we included some information on that as well at the end of this presentation. Learning objectives are defining female athlete triad, REDS, and some other important terms, comparing and contrasting screening recommendations, comparing diagnostic framework, and then looking at treatment recommendations, and then looking at how to have a clear return to play protocol for athletes. Starting out with some terms, the big one is female athlete triad. So a condition we typically see in physically active people of the female sex involving 3 components. So low energy availability, menstrual dysfunction, and low bone mineral density. Energy availability is the dietary energy we have at the end of the day after we've accounted for all the energy we've used for exercise. There's a calculation you can see in the middle here for how we get to that number. And then low energy availability is any discrepancy between how much we take in our food and how much we're expending. Some more definitions, just comparing eating disorder versus disordered eating behaviors. So eating disorders are going to be mental illnesses that meet DSM-5 criteria for eating disorders, and then disordered eating behaviors are any out of the norm activity around food or exercise. And just touching on menstrual dysfunction is any lack of a regular menstrual period, and functional hypothalamic amenorrhea is a complete cessation of menses in the absence of any anatomic abnormality. So female athlete triad model, the right side of your screen here in the green is what we want our athletes to be at. So optimal energy availability, optimal bone health, and then eumenorrhea. This middle part with the blue is kind of the gray zone where you're getting away from the ideal. So reduced energy availability, subclinical menstrual disorders, so this can be your oligomenorrhea, and then lower bone mineral density. And on the left here in red is what we want to stay away from. So again, low energy availability. This can be with or without an eating disorder. You have functional hypothalamic amenorrhea or cessation of menses because of the suppression of the hypothalamic pituitary ovarian axis, and then osteoporosis. So in looking at how are we screening for female athlete triad, this should really be a part of your pre-participation eval and done on a yearly basis for all your athletes. And any positive sign of the female athlete triad should be looked into further. On the right side of your screen, you can look at some example questions of what would we ask our athletes to kind of look into the female athlete triad. So looking into how is your period, fracture histories, looking into weight or questions about body image. So how do we diagnose low energy availability? There's obvious signs or overt signs that we look for. So people who are underweight, in this it's defined as BMI less than 17.5 or a expected body weight that's less than 85% of expected in adolescents. Otherwise, you can look at decreased fat mass, lower resting metabolic rate, a low T3, can be other indicators. And sometimes your athletes are going to have low energy availability, but maybe at a normal weight, so not as obvious. If this is the case, you need to have an accurate picture of how much they're actually taking in and how much they're expending in their training. Very hard to do because people have poor recall of their food or just aren't like as honest as you'd like them to be about how much they're taking in. And it really takes a practice like a sports dietitian or an exercise physiologist to have a good picture of this. And this last bullet point, athletes need to consume at least 30 kilocalories per kilogram fat-free mass per day, ideally 45. This was done in a experimental lab situation, so not necessarily very applicable to the real world when athletes aren't just in the lab. And this was only done in female athletes, but it gives a good idea of roughly how much people need to take in per day. So diagnosing amenorrhea, the big thing is getting a good history and exam, because that'll put you down the right pathway for what you're thinking about for cause of amenorrhea. Firstly, ruling out any outflow tract disorders or uterine pathology or any disorders of sexual differentiation that maybe weren't caught earlier in life. Once you've ruled those out, you can start your physical exam, like more in-depth, and labs. So looking at your gonadotropins, prolactin, thyroid hormones, other hormones, doing a progesterone challenge, and plus or minus a pelvic ultrasound. And of course, ruling out pregnancy. So once you've done all that, got your objective data, you can go into buckets. The big bucket that we're looking for our female athlete triad is on the left here. So typical findings would be low to normal gonadotropins, which makes sense because if you're not producing a lot of estrogen, you're suppressing your LH, FSH, so those would be low or normal. Negative progesterone challenge test. So when you're doing that 10-day challenge, you're not getting a menstrual bleed after that. And then possibly increased prolactin. So those will get you into that functional hypothalamic amenorrhea category. When looking at bone mineral density, we think about who and how to screen for this with a DEXA. So you can have high risk triad factors. So anyone who has been diagnosed with an eating disorder, those low body weights or body mass index that we talked about earlier, delays in menarche, more than 16 years of age, or irregularities in their menses, and then looking at their fracture history. So those are high risk ones. And then the moderate risk ones are basically the same thing, just kind of taken down a notch and not as severe. And you can also look at athletes who have a history of fractures that are traumatic, especially if it's greater than one in a non-peripheral fracture, and then greater than 2 in a peripheral long bone fracture should be considered for testing with DEXA. And then just defining how we look at low bone mineral density and osteoporosis in children and adolescents. I just included this one since the amount of like bone mineral density that we get is usually all the way put in like our adolescent time. So this is like really important to make sure our adolescents and young like athletes are having good like bone mineral density. So this would be looking at a clinically significant fracture history, and then looking at their Z-score on the DEXA scan to define that. So how are we treating the female athlete triad? The first line is going to be your non-pharmacologic treatments. So basically for menstrual cycle restoration, low energy availability reversal, and low bone mineral density, it's all the same treatments. It's weight gain using increased caloric intake and then decreasing training volume. So this all really fits in together. Once you fix one, you kind of start to fix the others. The only thing with low energy availability reversal, if it's unintentional working with like a dietitian, if it's more disordered eating, clinical eating disorders, you're going to pull in some of your mental health colleagues and definitely a sports dietitian for them in utilizing that multidisciplinary team. So return to play protocols, we're going to individualize this based on the athletes, individual factors, utilize our multidisciplinary team, and then use those to put them into risk stratification. So looking at the risk factors that we use to get points, we're looking at low energy availability, low BMI, delayed menarche, oligomenorrhea or amenorrhea, low bone mineral density, and then stress fractures / reactions history. And based on that, you get certain amount of points. So you can have low points or 0 points, moderate risk, 1 point, high risk is 2 points each. And you add those up to get into your clearance classification. So your athletes who are very low risk, 0 to 1 point, will have full clearance. If they're kind of that moderate risk category, 2 to 5 points, they can either have provisional clearance or limited clearance. And then anyone who's greater than or equal to 6 points falls into that really high risk category and will be restricted from training provisionally or disqualified. This slide just kind of goes over those clearance categories again in a little bit more detail. So provisional means the athlete's fully cleared, but have certain training recommendations that they're following. Limited clearance for those moderate risk athletes. Again, they have restrictions on training and competition, but these can be reassessed and increased if the athlete has good progress. If they're restricted from competition and training, provisionally, you are taking them out, but then reassessing after they've meeting certain health goals. And then disqualified athletes are usually those with poor prognosis that need a little bit more inpatient or intensive outpatient treatment before they can be reassessed for return of play. This slide just kind of summarizes all the things that go into our return to play decision. So looking at the medical factors of your athlete, looking at the sport risk modifiers, and then your decision modifiers to get to that return to play decision. So just touching on some of the updates from the 2023 consensus statement. We now use the term relative energy deficiency in sport, or REDS, or RED-S, depending on who you ask. So this term is a lot more inclusive than female athlete triad. It includes both female and male athletes, and then includes a wider variety of physiological and psychological impacts that low energy availability has. This picture here is just demonstrating all the different body systems that having low energy availability can impact.
No, you smoke shit around.
This,
goddamn it to your mom who's like
this next slide
person.
looks at how much the different impacts low energy availability can have on performance. So we also have expanded categories of low energy availability. So adaptable low energy availability is really just that short-term experience that can have minimal or no impact on our athletes' long-term well-being, where problematic low energy availability is the long, prolonged, very severe low energy that impacts those body systems we saw on the previous slides and performance aspects. So just briefly touching on screening for REDS. First step is using screening tools. There's a lot of tools available out there. They list a bunch in the consensus statement, so I encourage you all to look at those, but there's a bunch to choose from. And based on your screening, you go to step 2, which is your severity or risk assessment. The difference here is that instead of the low, moderate, high risk categories, we've moved more into color categories. So green, yellow, orange, and red. And you get your athletes into these different systems based on their primary or secondary factors or indicators and how many they have. They list them out in the paper, so I encourage you all to look at that. But basically, it's looking at similar lab results, fracture history, menstrual cycle, bone mineral density in getting these athletes into different categories. And then based on what category they fall into, you look at your diagnosis of REDS and then your treatment category. This is, again, pretty similar to the different clearance levels that were in the 2014 statement. They just have the color coded, so 4 categories instead of 3. But again, it's either like no treatment required, full clearance, can have training, but may need to like have closer follow-up, limited training with follow-up, and then your athletes who are really high risk, who are needing more immediate treatment than maybe can be provided while they're on the team fully. So primary prevention and treatment of REDS. One big change from the 2023 consensus statement was the focus on primary prevention, increasing education and awareness amongst both athletes and coaches, and then using early identification, screening, athlete assessments. And then tertiary prevention is pretty similar, using weight gain with caloric intake increase, and then decreasing training volume, and treating any other comorbidities, so eating disorders, depression, and then again utilizing that multidisciplinary team approach, and including like team support, coaching, families in your team. So overall, just a summary, REDS, or relative energy deficiency sport, is a bit more inclusive of all athletes and includes a larger constellation of symptoms than the previously used female athlete triad. When you're categorizing risk for athletes, it's very individualized based on their characteristics, circumstances, and different health outcomes. Our first line treatment is always non-pharmacological, so increasing energy availability, and then treating any other complicating health issues, including our multidisciplinary team, and then individualizing our clearance and return to play. So here are my references, and I'd just like to thank you all for listening and welcome any questions, comments, concerns.
Thank you, Dr. Busse, for that great presentation. I'm going to turn it over to our club mentor, Dr. Chamberlain, for any additional comments, and feel free to answer the question in the chat if you like.
Yeah, hopefully you can all hear me. My Wi-Fi seems to be a little spotty, but I think Aundrea did a great job summarizing a pretty complicated and like ever-evolving topic, especially with the 2023 updates. And I think that if you go back and reference the 2023 updates, it has a great table. I think it's table 2, and it reflects on that conceptual module of all the different ways that RED-S, low energy availability, can impact different parts of the body, organ systems. And I think that if you look at it from that approach, you can kind of think of the way to primarily screen athletes that you might see in the office or for pre-participation physicals, because it has, like, from my experience, become a little more challenging. You can't rely on just like a menstrual history anymore with how many people are on birth control, which kind of skews menstrual patterns. So thinking about other areas that can be impacted by low energy availability. So I've seen athletes that just get sick a lot. You know, they're at college, oh, I just get colds all the time, but that could be an early sign of low energy availability, even GI dysfunction, motility dysfunction, subtle things that you might not think are relevant, but can become part of your history taking, especially for these athletes in like high endurance sports, and athletes, especially athletes, I think, transitioning from high school to college. You know, you get a freshman that's not used to that training load. It doesn't mean they have an eating disorder or they have any disordered eating patterns. They're just not, they don't understand the nutrition and the energy they need to be taking in order to fuel their bodies. So I think, just like you said, and with the 2023 consensus statement, primary prevention screening is really I think where you can find or I guess catch some of these athletes a little earlier than if they go on into full RED-S. And then the last thing I would mention would be education, because I think hopefully it's getting a little bit better, but especially education of coaches, especially for like female athlete sports. is a particular issue and is much value. So if you're working with teams, being in good communication with the athletic trainers and the coaches, so they can also help recognize some of these earlier signs.
Thank you, Dr. Busse and Dr. Chamberlain. We'll be moving on to the third presentation. So our presenters are Dr. Annika Lenz and her club mentor, Dr. Griffin Elbert. So Dr. Lenz is a second-year pediatric resident at the University of Utah, specializing in sports medicine with an emphasis on preventative care. She was raised in Los Angeles, California, with her 3 sisters, and they were all involved in diving. She competed both collegiately and internationally for the US for diving. A graduate of UCLA and USC Medical School, she discovered her passion for sports medicine during residency. Dr. Lenz is particularly intrigued in the impacts of early sports specialization and the intersection of nutrition and athletic performance. Her presentation is on the periodized nutrition for athletes. I'd also like to thank Dr. Griffin Elbert for serving as her club mentor. Dr. Elbert is a family medicine and sports medicine physician for Community Memorial Healthcare in Ventura, California. He obtained his medical degree at Marian University College of Osteopathic Medicine before completing his family medicine residency at Community Memorial. After this, he completed his sports medicine fellowship at UCSD. Okay, go ahead, Dr. Lenz.
Okay, I think I was muted.
Oh,
Sorry.
you're good. We can hear you
Okay.
now.
Okay, cool. I just said I had the privilege of working with Dr. Elbert, and thank you AMSSM for letting me talk here. I looked at the article entitled Periodized Nutrition for Athletes. Here's just a screenshot of this article. It was published in Sports Med in 2017 by the author Asker Jukendrup. So some learning objectives for this talk include understanding the concept of periodized nutrition, reviewing the nutritional training methods, and understanding the study goals, outcomes, and limitations of various studies that were talked about. So the author defines periodized nutrition as a planned, purposeful, and strategic use of specific nutritional interventions to enhance the adaptations targeted by individual exercise sessions or periodic training plans, or to obtain other effects that will enhance the performance longer term. So this is not the same thing as dieting, which is often used with restricting certain foods in order to kind of lose weight, while periodized nutrition is more about choosing specific types of foods and the timing of them in order to enhance these adaptations that will help us with our performance. So like I mentioned, just the general background for periodized nutrition, it can be either this combination of exercise or training and nutrition, but it also can be nutrition alone, with the goal of overall obtaining adaptations that will support this exercise performance. In the 1800s, it was the first time that training was referred to as a regimen that included both exercise as well as diet, and it was aimed at short-term performance benefits. So there's some methods that have been found their way into training methods of a lot of athletes, even though their efficacy has not necessarily been shown to be effective in improving their performance. Sorry. So why is this relevant? As we all know, nutrition plays a huge role in athletic performance, and these adaptations that are initiated by exercise can either be amplified, but they can also be reduced by nutrition. And there's a lot of research out there that focuses on skeletal muscle adaptations, but not a lot in other organ systems such as the brain, intestine, and vasculature, which are also very important for sport performance. A lot of nutritional recommendations for athletes regarding eating are promoting the acute recovery after exercise, but the careful planning ahead of training with long-term goals in mind are often uncommon and are still developing in research. So what are the study goals? The author wanted to define the concept of periodized nutrition, which is also known as nutritional training, wanted to summarize and provide a holistic overview of a variety of methods available to athletes with the emphasis on adaptations that are not in the skeletal muscle. He goes in detail a little bit about the gut adaptations in his paper, and then identifying some of the remaining questions that may have a great practical relevance and should be the focus of future research. So the design of the study was a literature review. So as the previous presenters, mine's not going to be the typical format, but I will be reviewing some of the studies that are mentioned in this review. This is just a list of the different nutritional training methods that are discussed in this article, including training low, training high, training the gut, training dehydrated, and training with supplements. And for the interest of time, I'm just going to focus on some of the studies within the training low category, which is a pretty big category, and then briefly talk about training the gut. So as you can see, there's many different subtypes within training low and training high, and I'll have another slide about the other ones as well. So there's many different ways that athletes can use to kind of alter the nutrition to adapt and make some hopefully potential improvements in their performance. This is just a couple different ways that you can train the gut, including training for stomach comfort, training gastric emptying, absorption, race nutrition. And then he also goes into a little bit about training adaptations with supplements, which I did not have time to go through for this presentation. So what is training low? This is training with a low carb availability, and the rationale is derived from an observed link between carb availability and gene expression. So low muscle glycogen content has been demonstrated to enhance the transcription of many genes that are involved in training adaptations. And skeletal muscle is generated by this cumulative effect of these transient increases in these gene transcriptions during the recovery from repeat bouts of exercise. One type of training low is training 2 times a day. So this is where you have limited or no carbs between 2 sessions. So the goal of the first training session is you're lowering that muscle glycogen so that during the second training session, you're performing that in a low glycogen state. And that is thought to increase the expression of relevant genes that would then result in adaptations that would favor the fat metabolism. However, it's too early to conclude that this training method will result in the long-term performance benefits. One of the studies that he looks at in his paper includes 14 well-trained cyclists, and they're either training twice a day every other day, so getting into that low glycogen state, or a group is training once every day, so they're not getting into that low state. And they found that training low improved the ability to use fat as fuel. However, there was no differences in the performance after 3 weeks of training low compared with the control group. Just a summary of the different studies that the author reviews about the training 2 times a day basically found that there was relatively short training periods in the studies, and so that therefore was insufficient to demonstrate changes in performance. So training twice a day may result in some adaptations that favor fat metabolism, but it's too early to conclude if it will result in long-term performance benefits. Next is training fasted. So this is another in the training low group. So this is when you're training in an overnight fasted state. So typically eating dinner around 8 to 10 p.m. the night before, and then you're exercising the morning before you're eating breakfast. So your muscle glycogen should be unaffected by this overnight fast, but your liver glycogen will be low. Studies to date have focused on metabolic adaptations, but few have addressed the effects or potential effects on exercise performance. So one of the studies that the author looks over is including 10 moderately active males, and they're performing an endurance training program either in the fasted state versus in the carb-fed state. And they found that neither the intramyocellular triglyceride content breakdown nor the fat oxidation rates during the exercise were altered by training. And they found that the short-term training elicits similar adaptations in the peak VO2, whether carried out in the fasted or the carb-fed state. So just a summary of the training fasted studies that he reviews. Like I mentioned before, studies have focused mostly on these metabolic adaptations, but few have addressed effects on exercise performance, especially the long-term effects of the performance. And there's still a lot of limitations and questions that are unanswered, including how many days of training per week are needed to see these effects, what type of training, intensity, duration is the most suitable for fasted training, and how many weeks should this training be performed in order for you to see meaningful effects. Another type of training low is the type of diet including a low carb, high fat, or ketogenic diets. And the goal of this is to get into a long-term low carb state. It has been suggested that chronic use of carbs during exercise may limit training adaptations, because long-term glucose ingestion may negatively affect the expression of relevant genes. One of the studies that is reviewed in this article is looking at 9 healthy, physically active male subjects. They're performing one-legged knee extension training, either while ingesting glucose or while ingesting placebo. And they found that the glucose ingestion did not alter training adaptations related to substrate metabolism, mitochondrial enzyme activity, glycogen content, or performance. The ketogenic diet study that the author reviews includes 5 well-trained cyclists, and they ate a eucaloric balanced diet for 1 week, followed by 4 weeks of a eucaloric ketogenic diet. And they found that the participants did achieve a physiological adaptation that conserved the limited carb stores, both the glucose and the muscle glycogen, and made fat the predominant muscle substrate at this submaximal power level. And they found that the aerobic endurance exercise by the well-trained cyclist was not compromised by the 4 weeks of ketosis, but they did not show any improvement in the performance. So summary of this ketogenic study that is often cited. In the study, the exercise capacity was only tested at a low intensity and showed a large degree of variation both between subjects and within subjects. And there has not been a single study that has demonstrated the performance benefits of a ketogenic diet. So there's no data on ketogenic diets in athletes on which to perform performance claims. Another type of the training low is sleeping low. So this is when you're training late in the day and you go to bed with carb intake restriction. So it's essentially the same idea as low carb availability after training, but the period post-exercise is extended. So here, both your muscle and your liver glycogen will be low for several hours during sleep. Just a summary of some of the sleep low studies that are reviewed. So there's actually only been 2 studies on this concept of training high and sleep low, so it's too early to draw conclusions on this. The studies assess acute changes and not long-term effects on metabolism or performance, which is kind of a theme for a lot of these studies, that it isn't really looking at the long-term performance effects. There's also still a lot of unknown potential side effects of these sleep low studies, including what are the effects on recovery when applied frequently, what are the effects on immune function, and what are the effects on the quantity and quality of sleep. And I'm going to briefly mention training the gut. So GI problems are very common, especially amongst endurance athletes. And some of these symptoms may be caused by the fact that the intestine is not adapted to absorb nutrition well under stress. So blood flow to the intestine is reduced when you're doing intense, prolonged exercise, and dehydration on top of that seems to exacerbate this effect. So intestinal absorption is the main barrier to delivering carbs to the contracting muscle. So training the gut could help develop gut adaptations that would improve the delivery of nutrition and reduce the prevalence or severity of GI symptoms during exercise. So it's just a summary of some of the gut studies that are reviewed in this article. They found that nutritional training can improve gastric emptying and absorption and likely reduce the chances and severity of GI problems, which would improve endurance performance in the experience for the athlete. However, there's still a lot of future studies that could be done, including more human studies, focusing on the most effective methods to induce gut adaptations, understanding the timeline of these adaptations, and obtaining a better understanding of the exact mechanisms. So just an overview of some of the outcomes and goals of the study. So primarily, it was to understand the common methods of nutritional training, understanding methods to improve gut function, and understanding certain supplements, how they affect training, which I was not able to get into. And some secondary goals and outcomes included identifying gaps in knowledge to better understand how to integrate periodized nutrition into training methods, identify data lacking to formulate practical guidelines for many supplements, and identify the need for research assessing whether methods have superior long-term adaptations. So last slide, guys, almost made it. So study conclusions, we found that manipulating nutritional intake allows one to promote training adaptations. The appropriate practical application lies in the optimal combination of these different nutritional training methods. And there's many variations within each of these methods. Not one method will address all needs. So they should be used depending on the specific goals of the individual. And overall, there's still a lack of studies that show that these methods will result in superior adaptations in the long term. And that's just my references. And I'm done now, so any questions or anything?
Thanks, Dr. Lenz. That was awesome. I'll turn it over to Dr. Elbert to see if he has any additional comments. And I think Dr. Troxler has a question in the chat if you'd like to answer that.
Yeah, I can answer that here at the end. I apologize for my voice as well. I'm getting over a sickness right now. I'll keep my comments brief for the sake of time and because Dr. Lenz did such a good job going over everything. The main theme of this was basically limitations with everything. There are many different methods that you can try to periodize the nutrition to provide certain adaptations. But a lot of it is based on theory of how they might affect different mechanisms, different gene transcription and enzyme activity and stuff like that. But basically, a lot of what we saw is that it didn't correlate over to true performance, and that is the real reason why you want to try to do that in the first place. For a lot of it, they were limited by only having a few studies to base off of, or they were limited in the time frame, which obviously periodization in and of itself is more of like a chronic term thing. So we want to be looking more for longer term studies to be done. Additionally, each of these is going to affect each person differently. So one of those last slides there was talking about, it's got to be individualized to the person. And I think that is just spot on. Each of these methods might affect someone differently, not only how it affects their gut or how it affects their sleep, or maybe even just their emotional well-being or their mental health as they go into a training session as well, because all of that is going to impact their performance as well. Additionally, all of these were about basically manipulating carbohydrate intake or specific macronutrients, not necessarily limiting energy availability. So especially as we come off of the Red S presentation, we want to make sure that they are still getting enough energy in, that they're not falling into that low energy availability state and having negative performance because of that as well. Regarding the question in the chat about the role of caffeine, that was mentioned a brief bit in the section about supplementation that has shown to be beneficial in many aspects, not only for anaerobic, but also aerobic activity. So that can definitely be beneficial more in the acute setting rather than even the long-term periodization where this article is addressing. There are multiple other supplements within there as well, like creatine and sodium bicarb and other things like that, which can be used. One thing I would note on that, though, is a lot of times people will jump straight to supplements rather than addressing the diet as a whole or the entire training program as a whole, where those are going to be your foundations, how well the person is sleeping, how well they're dealing with stress and all that. That should be the foundation. And then supplements are going to get you that extra, 0.5 to 1% or something like that. So addressing all the other things first should be key.
Thank you to all of our presenters for an awesome journal club, Dr. Banerjee, Dr. Busse, Dr. Lenz, and their club mentors, Dr. Asplund, Dr. Chamberlain, and Dr. Elbert. I'd also like to thank everyone for attending tonight's AMSSM December Journal Club meeting. It was my pleasure serving as your moderator. Just a heads up, in January, we're going to be having 3 different Journal Club meetings. They'll be on Monday, January 8th, Tuesday, January 9th, and Tuesday, January 16th, all at 8:30 Eastern Time. So we will see you guys there. This concludes tonight's meeting. Thanks, everyone.